Good evening, everybody. Thank you very much for being here. Welcome. I want to just do roll call and get us going. So Dr. McNeil is not present.
Yep.
Commissioner, we lost you. I will text you.
Very quickly to the members of the public who've joined, we were in the middle of roll call and Dr. Reval Nelson's computer is frozen. So we are just getting her back online and then we'll continue with roll call and get back to the agenda.
Hi, can you all hear me now?
Yes, ma'am, you look good.
Okay, great. Sorry about that. Should I roll call again? Were folks able to hear me or no?
We got through Dr. McNeil. So if you want to just start over and get it all in one shot, we can go.
Thank you. Sorry about that. All right, Dr. Gold,
Here.
Dr. Tyra Bryant-Stevens,
Here.
Dr. Ishmael is not present. Dr. Ibrahim,
Here.
Dr. Dean Rule is not present. Dr. Bilal.
Here.
Wonderful. Has the board had an opportunity to review the minutes from the last meeting, which, as requested, were briefer and made available?
Yes.
Wonderful. Do I have a motion to approve the minutes?
I'll make a motion to approve the minutes.
Second.
All in favor of approving the minutes?
Aye.
Aye.
Aye. The minutes are approved. And now we have two regulations that we wanted to talk about. And I'm gonna turn it over to Ben and the team to do those. And then towards the end, I can give an update about what we're doing for the One Philly SNAP program and how the health department's been involved in the funding aspect of getting money in the hands of Philadelphians that provide food services to other Philadelphians. So Ben and team.
Thank you, Commissioner. So yes, there's two regulations to be reviewed today. One being the regulation relating to the Philadelphia Families Can Centralized Intake Data System, and the other a regulation relating to severe maternal morbidity surveillance. Sorry, Sarah and Ellen, I didn't discuss this with you before, but if one of you has the, time constraints, not sure who wants to go first, but it's up to you. If no one, if there's no strong preference, then Sarah looks like you unmuted to me.
Go for it, Sarah.
Sure. Yeah. Should I just jump right in?
Yes. So you're gonna present your information to the board, and then I'll go through the regulation. Thanks.
Which one is this? I'm sorry.
This is maternal morbidity. Sorry.
Okay.
Are you seeing my PowerPoint?
Yes.
Are you seeing it as a presentation or like with my notes?
With your notes.
Okay.
All good.
Hi, everyone. My name's Sarah Weinbaum. I use she, her pronouns. I'm an epidemiologist at the Division of Reproductive, Adolescent, and Child Health, or REACH. So I'll be presenting today about our proposed regulation for severe maternal morbidity, or SMM, surveillance. So first, I'll talk a little bit about what SMM is. I'll review a little bit of data on SMM in Philadelphia. I'll discuss how we're using our Maternal Mortality Review Committee as a model for SMM review and surveillance, and then I'll talk about the proposed regulation. So when we talk about SMM, we're talking about serious, potentially life-threatening complications related to labor and delivery that can have both short and long-term impacts on the health of both birthing people and their babies. SMM is generally considered an important marker of overall perinatal health within a community. There is, however, no consensus definition of SMM in terms of the inclusion and exclusion criteria for what actually counts as an SMM case. Previous efforts for surveillance in Philadelphia have used an SMM definition that was developed by the CDC. It uses ICD-10 administrative codes, diagnostic and procedure codes, to define SMM. So our division has produced 2 reports over the past several years. The image on the screen is from our most recent report, which came out last year. So next I'm going to go through some of the data from our most recent report, which again uses this ICD-10 code-based definition of SMM. So SMM rates are increasing over time in Philadelphia. From about 2018 forwards, we've seen a general increasing trend in the rate of SMM. This is consistent with what we're seeing at the national level, so it's not just Philadelphia. We are overall seeing that SMM rates are increasing over time. We are seeing that people aged 35 plus at the time of delivery experience higher rates of SMM compared to those under 35, and also that those under age 20 experience slightly higher rates compared to those in their 20s and early 30s. We see that there are racial and ethnic disparities in Philadelphia in SMM rates, with non-Hispanic Black birthing people experiencing the highest rate of SMM compared to other race and ethnicity groups, and non-Hispanic white individuals experiencing the lowest rate of severe maternal morbidity. We also see that the SMM rate is consistently higher among people who have a C-section delivery compared to those who have a vaginal delivery. We see that the burden of SMM is not evenly distributed across the city. So there are certain areas, mostly in North Philadelphia and West Philadelphia, where birthing people experience higher rates of SMM compared to other neighborhoods. And these are what we see as the leading indicators of SMM. So these conditions correspond with the ICD-10 codes that the CDC uses to define SMM. So when we use that definition and we look at it this way, we see that the leading indicator of SMM, that most common ICD-10 grouping of codes that comes up, is acute renal failure, followed by disseminated intravascular coagulation, acute respiratory distress syndrome, and sepsis. And these data are really helpful in their own way, but they do lack context, and they leave us with a number of questions about what's actually going on in terms of people's delivery experiences. So, for example, when we look at these leading indicators per the ICD-10 code-based definition, we are left asking the questions, what caused this outcome? So if we're thinking about why someone might have an acute renal failure diagnostic code in their chart, that could be coming from a lot of things. That could be related to hemorrhage, that could be related to a hypertensive disorder. And when we're just looking at these sort of end of the line, what gets billed at the end of their delivery admission, it's really hard to know what the order of events leading up to this was. And then really importantly, was it preventable? And if so, how? Similarly, when we're looking at the differences in rates between C-section and vaginal deliveries, we have to ask the question, like, did the C-section lead to an SMM event, or was it performed in response to an SMM event, which are very different scenarios, and gets back to this idea that we don't have a timeline of events. And then when we look at this data that shows disparities in SMM rates, we ask ourselves, where are people falling through the cracks, and what opportunities exist to make things better? So we looked at these data and we asked ourselves those questions And we realized that we needed a more robust way of measuring SMM in Philadelphia to better understand what's actually going on during people's delivery admissions. So in 2024, we launched our active SMM surveillance system at all 5 of the birthing hospitals in Philadelphia. You may remember reviewing sort of part 1 of this regulation, which was passed in January of 2023. So that regulation allowed for hospital representatives to report patients that meet our REACH case definition of SMM into our REACH hosted database. That's been going very well. We have 6 quarters of data so far. And so, as I mentioned, the ICD-10 code-based definition has some shortcomings in terms of giving us clinical context about the patient. So we decided to create our definition in collaboration with hospital representatives, and we tried to make a definition that gets more at the clinical outcomes that patients are experiencing. So the case definition that we are using is any patient who meets at least one of the following criteria. They receive a blood transfusion of 4 or more units during their delivery hospitalization. They're admitted to the ICU during their delivery hospitalization. They have an extended length of stay following delivery, which we have defined as 5 or more days, or they're readmitted to the hospital within 30 days of delivery. And these are all the data elements that we are currently collecting as part of our active surveillance system. So some of them come straight from the electronic medical record, things like patient's name, date of birth, MRN, their race and ethnicity, date of delivery, gestational age at delivery, vaginal or C-section delivery, comorbidities, and we're using the CMQCC SMM risk score index to track comorbidities, their length of stay in the hospital, and which of those 4 SMM criteria they met. And then some of the information we're getting is from chart review that staff, hospital champions at the hospitals are doing abstraction for us and entering it into our database. So some of the things that they're looking at the chart and giving us information about are the circumstances around C-sections. Was it prime or repeat, planned or unplanned? If unplanned, why? And then in their own words, the reason that the patient met one of those criteria. So like, why did they need a blood transfusion? Why were they admitted to the ICU in the abstractor's own words? And then they're also giving us a copy paste of the patient's discharge summary. And then the other piece of information that we currently have access to is linkage to vital records. So we are linking to the corresponding birth or fetal death certificate for each delivery occurrence. And then if applicable, we're linking to maternal or infant death certificates that happen subsequently. So in continuing to develop this surveillance system, we're really using our Maternal Mortality Review Committee as a model. So the Philadelphia MMRC identifies and reviews all cases of pregnancy-associated death among Philadelphia residents. And after case identification, the cases are investigated via full medical and social service record abstraction, which our abstractor uses to craft a detailed case narrative. And that case narrative is reviewed by a multidisciplinary expert committee. The committee then makes determinations about the causes of and factors related to the death, and they make recommendations to prevent future deaths. And we have seen in Philadelphia and around the country that MMRCs are really effective in terms of identifying priority areas for improving perinatal health. So as we're using our MMRC as a model for building up our SMM surveillance model, this is sort of a checklist of where we are and where we would like to go. So we've developed our system for timely case identification. In terms of medical record abstraction, we're getting there. We have some of the information that we want from our hospital abstractors, but we're not doing full record abstraction. We're not currently looking at social service records, and we have not yet convened our multidisciplinary committee, who will be the ones making informed expert recommendations to prevent future cases of SMM. So those are kind of our next steps. In order to expand our surveillance program, we're proposing this new regulation to establish an SMM review committee modeled after our MMRC to review cases of SMM and make recommendations for improvements to perinatal care in the city. This regulation would allow REACH staff to request medical and social service records for identified SMM patients for full abstraction and to create detailed case summaries. And it would allow REACH staff to share de-identified case summaries with members of the SMM review committee, who will then make recommendations for prevention. We see several benefits to PDPH and to Philadelphia through setting up this review committee. Currently, our surveillance system is only collecting a small subset of patient information that is being entered by staff members at the hospitals, but full record review will allow an expert abstractor to consider the full context of a patient's SMM experience. The review committee will draw on expertise from a multidisciplinary group of people across the city, so our recommendations for action will be able to draw on a wide range of expertise. And it'll coordinate efforts across the city. So the committee recommendations will be used to identify priorities, generate collaborative initiatives at the city level, get everybody on the same page, and identify things that are trends at the city level to get together and work on priorities together. So just kind of in summary, this proposed regulation is aimed at giving REACH the authority to obtain medical and social service records so we can do full case abstraction and allow for the formation of the SMM Review Committee.
Thank you very much. Ben, can you please share the regulation and then we can see if the board has any questions.
Thanks, Sarah. Yes, I will do now. Is everybody able to see my screen? Oh, now maybe it's coming through now. Okay, great. So this is the regulation relating to severe maternal morbidity review. The whereas clauses establish the ability of the department to and the Board of Health to create a reportable condition, which was done through the January 2023 Board of Health regulation establishing severe maternal morbidity as a reportable condition and establishing the surveillance program that Sarah just laid out. And it also sort of goes through the rationale in brief that Sarah presented to you just now. Moving down, the definitions set out, what a case subject is. It's somebody who's been identified by the surveillance and, puts into context all of the terms that are used in the regulation body. And then the operative parts of the regulation are establishing the severe maternal morbidity review team. And as Sarah mentioned, that'll bring together representatives from governmental and non-governmental and social service provider organizations to form the review committee. And the information that we're looking to collect for that committee is presented in section 3. I'll let you take a look at that. And this also establishes that the department's conducting these activities as a public health authority under HIPAA. And finally, section 4 and 5 deal with privacy and security of the data. These will be de-identified reviews as discussed by Sarah, and that there will be confidentiality agreements signed by the review team members to make sure that this information is held pursuant to applicable law. So I'll stop sharing. Dr. Gold, do you have a question? Sorry.
Yeah, no, it's a question for our
Okay,
presenter.
great. I'll stop sharing.
So thank you for that. Understood. Just for clarification, and if you mentioned this, forgive me. The current MMR, like, why do we need an additional system? Why is the system that's currently working on this and has been for a long time not enough to pick up this sort of subset, I gather, right, of a level of severity among birthing people?
So it's a great question. Thank you. They are different populations. So our current committee is maternal mortality review. So these are people who die per the definition of a pregnancy-associated death, people who pass away during pregnancy or within a year after pregnancy. This new system is severe maternal morbidity. So these are not people who died. These are people who had a sort of serious, clinically adverse delivery experience, but they did not die. And it really builds on our knowledge of perinatal health in the cities. because maternal mortality is, while our rates in the US are much higher than sort of similar countries elsewhere in the world, the absolute number of cases is quite small. So we can't do too much. It's just a little bit harder because the case number is so small to like look at trends over time, because we only really see 5 to 10 cases a year. Whereas with severe maternal morbidity, we expect to see several hundred cases a year. So it's sort of a much more robust data source for us to really look at trends a little more deeply and a little more reliably than we can with maternal mortality review.
Thanks.
Oh, I had a couple of questions. One is you mentioned making recommendations. Who are you making these recommendations to?
So in modeling after the MMRC, we make recommendations at several different levels. So we make system level recommendations, which might be aimed at government agencies. It might be aimed at healthcare systems. We make provider level recommendations, which might be aimed at this case at labor and delivery providers, possibly prenatal care providers. And then we make community level recommendations, which might be recommendations for community-based organizations, things that we're seeing as gaps that could be filled and ways to partner with the community. So it's pretty broad.
Someone else can ask a question.
Can I
Please go ahead.
piggyback? I was gonna say, can I just piggyback on that question? Dr. Brian Stevens, I had the same question about who it was going to, but Sarah, can you speak a little bit to the feedback loop? My concern is these recommendations happen. What is that feedback loop in terms of being able to look at the evaluation to say, are we seeing an impact? So I see the surveillance side. I'm just concerned with that feedback loop. Can you speak to that a little bit more?
Yeah, so our current structure within REACH, we have our entity called Birth Justice Philly, and our action arm is called the OVA, the Organized Voices for Action. And that's who sort of implements our recommendations or partners with community members to implement recommendations from the Maternal Mortality Review Committee. So when we set up initiatives, we always make sure to have an evaluation plan in place before we get going on that initiative. And trying to think of like a recent example would be our perinatal SUD warm line. So some of the recommendations that came out of the Maternal Mortality Review Committee were that providers didn't have enough information to care for patients who had SUD while pregnant. So we partnered with some of our people in our network at Penn and CHOP to expand the Care Connect warm line to include expertise in perinatal SUD. And we're partnering with a group at Penn to evaluate that project. So we sort of, as we identify potential interventions and put recommendations into action, we're always thinking about evaluation, in the beginning stages.
Thank you.
Thank you.
I had a question on another feedback loop, which is whether this can help inform, since you'll have the original codes and the result of the review itself, can this inform future passive surveillance using those codes? So I think that's a much less intensive work, right?
It could potentially, and I think that work is still sort of happening really across the country. As I mentioned, there is no consensus definition of SMM, and a lot of people are similarly doing work to figure out what types of surveillance systems are going to work best for, their jurisdictions, whether it's passive or active, and what actually captures sort of the most relevant subset of cases. But definitely, I think the more we learn, the more we can refine either this surveillance system or if this, it ends up evolving into something new and better.
And just related to something you just mentioned, is there any other similar surveillance system for maternal morbidity? Sorry.
Yes, Maryland has a similar system, and we talked with them a lot in developing our current surveillance system.
So just to piggyback on that, what did you learn, and are there opportunity? I mean, I assume that some, at least the lessons learned in Maryland would be applicable to us. And is there an opportunity to maybe implement some of those lower intensity measures in the meantime? Because am in support of the system, but as we mentioned, like you can survey, you have a lot of surveillance, and the question is what happens at the end of the day. And I kind of think if there's already a group that's been doing this, are there lessons that we learned that we don't have to wait for to learn again?
Yeah, I totally hear you that surveillance, just knowing the data doesn't always give you all of the answers that you want. And I actually think that's why the committee is going to be such a key piece of this, because I can run numbers all day. I can tell you, the rates and the trends, but unless we have people who work in Philadelphia with these populations who can look at the cases and talk to each other and, you know, kind of establish like, yeah, this is what's happening over here where I work, and I work in this, specific niche over here. Like, what can we do together? So I think, yes, we can learn lessons from other places, but what's going to work best is having people who work with this population in Philadelphia who know what's going on, and can like make recommendations that work for our city, which to me feels like the next piece of the surveillance work, to give them the cases and say, this is what we're seeing and what do you think we can do about it?
And at the end of the day, to these points and these questions, right? Why do we, as a public health department, do surveillance and watch and keep track of these things? And why would we form another group? This is a specialized group to look at a significant trend that we've noticed. But at the end of the day, we're focused within the health department on upstream solutions. So whether we are forming a violence reduction council or our OD stat review, overdose stat review that we're hoping to relaunch and restart in February, or to follow up with the MMRC or this group, it's all about understanding the cases and the trends, and then coming back up to an executive collaborative group to make those decisions. So whether it's pivoting policy decisions within the health department or our community partners, that's the goal of making sure we're getting all this done. Dr. Ibrahim?
I guess that's one thing, and I'm just looking back through. I see in the whereas clauses that there's language with regards to developing recommendations, but going through the different components of the reg, that's the piece that I'm just not seeing. It's not clearly articulated, the recommendations piece in that follow-up, because I completely agree. There's tremendous opportunities for looking upstream. As this is written, I just don't see that recommendations piece as clearly articulated and that feedback loop in there. I hear we're talking about it, but I think that was my thing when I was reviewing the language, is that I just didn't see that piece in there. It felt like surveillance to do surveillance.
Yeah, I hear you. I think, and I might ask Ben if I'm correct here, but I think probably that has to do with the fact that implementation of recommendations is not so much something that it is like a HIPAA challenge. So I think this regulation is asking to give us the ability to form this committee and to have all of those records so we can get the case narratives together and the committee can review them. Whereas implementing the recommendations is sort of a programmatic piece of REACH's work.
And to that point, quite often the regulations, we don't spell out the recommendations, because then at every point we have to come back to make a regulatory code change. So this is by amending the regulation and putting it in place so that we have the capacity to have the meetings and to do this work, that then leads us to the ultimate recommendations without binding us through regulation. And Ben, if you want to speak on that, feel free.
Oh no, I mean I think you both covered it well, but yeah, I think ultimately prevent severe maternal morbidity in the last clause of section 2 is sort of meant to encompass the prevention piece is downstream of all those recommendations, I guess, is where I would point to in the regulation. But if If you want to suggest some whereas clause language or something to make it stronger, happy to do that. But it's harder to do that on the fly. I apologize.
So I think, yeah, it's just the feedback. It's not, there's nothing, I think, at least in my opinion, that's uh, wrong with the regulation as it stands, except for it just says recommendations. It doesn't talk about what happens afterwards. And I hear you, it says ultimately to prevent, but I like your explanation, Sarah, of what happens with that. And I think that's just what, Dr. Ibrahim was referring to. This is just not in there.
So I understand we would like to have a clause added in there, which typically that kind of summary clause that Ben was referring to is what is put into regulations. And that's where it's left to allow some legalese flexibility to address what needs to be addressed. So I would like to ask if the board is okay with leaving that language, and we can then follow up as the groups keeps meeting, if the regulation is passed, and provide updated reports and recommendations as we've been doing with the board.
I mean, that just to say that sounds fine. And hey, if you all feel that you need this level of surveillance in order to implement change, make recommendations, and hopefully lead to change, so be it. I do want to say it's a little disheartening how many years the kinds of morbidity and mortality among women or people who are birthing in Philadelphia have been going on. And there are only so many versions of what it is that goes wrong or what it is that can be improved, right? I mean, those of us who know this, I see Dr. Bryan Stevens' facial expression, like after a while, it's either people presenting late, and there are myriad reasons for why they're presenting late to the system. Some of those are the systems issues, and some of those are individual issues. And then there's when things really go wrong, most of the things that you showed are shock and acute renal failure, the kidneys shut down, there's DIC, there are all of these things that happen leading to severe, terrible outcomes. And we understand that. The gap between a natural gap of collecting the data and then being able to make so-called recommendations and then have a change in the system and then detect that the change has made a difference. These are massive gaps that have dogged us in every major city, for that matter, for a long, long time. So I don't know what the innovation is here. I don't have to offer it up. Don't know if any of my colleagues do, but I think that's the part that's almost a little disheartening, and why I asked about a committee that already exists, for example, because frankly, the experts, I guess minus the insurance companies in the marketplace, but the other experts already are on the larger committee that's been in place because they're experts in issues that happen along the chain that have a gradation of outcomes, but they are the same issues. So just putting it out there that these delays, like, okay, and a year, 2 years, 5 years, that we look as a city back at this and say, hey, it made a difference. How are we going to know?
Yeah, I have to add to that. Like again, this regulation, I don't have an issue with that, but the issue I have is that there's already evidence out there, you know, and so we already know what the issues are that leads to this, and I'm not sure that this is really going to help us reduce SMM.
I agree with both of those statements, with the caveat that you know, it may not help, but it may also help, right? We're at a point right now where, you identify the gaps when we look at the regulations and we look at when these discussions were had, how many years ago, and it's still an issue, right? So sometimes having them resurface and regenerated and brought through a regulation gives us an opportunity to then bring them to light and force the issue. One of the priorities, when I shared the priorities of the health department earlier this year when we had our meeting, one of the priorities for the department is really honing in on the specifically Black maternal mortality and what's happening in our city, and that we need to take action. So this is one of the things that is, it's not glamorous and glitzy, but it's taking us in a step to raise awareness and to make sure that with it in place, then that with the regulation in place, then comes accountability. And then comes a follow-up. And then comes the forced action, for lack of better words, so that we can make sure that there's not an evaluation that happens 2 years from now, but that it's on the forefront and happening. So I'm sorry, Dr. Ibrahim and Dr. Bilal both have questions.
So I just wanted to ask the point that Dr. Bryant-Stevens made, is there, I understand that we're adding surveillance, that we're looking at morbidity. And I understand that that's going to allow us to capture more data. But is there a need for having the two different review committees operate in silos, or can it actually be a morbidity and mortality review that they're reviewing both? Because it does seem that you're going to have very similar issues. I just was wondering what was the thought process for having the two separate.
Yeah. So I think a thing to consider is that maternal mortality, the span of time that can occur is from the start of pregnancy through a full year postpartum. We see very, very few cases of maternal mortality that occur during a delivery admission. So the Maternal Mortality Review Committee and this proposed SMM Review Committee are actually probably looking at very different time periods in someone's perinatal journey. Probably both looking a good deal at the prenatal period. But when I think about our Maternal Mortality Review Committee meetings, we are often thinking about the postpartum period. We're thinking about supports for people weeks to months after delivery. A very large proportion of maternal mortality cases happen in the postpartum period, whereas this committee, so SMM by definition happens right around delivery, usually while someone's still in the hospital. So the recommendations coming out of this committee are going to have a lot more to do with prenatal care and delivery care. I do definitely foresee overlap between the two committees. There are certainly folks on the MMRC that we would want to be part of this committee, but I think keeping them two separate committees lets us focus on these different time periods of pregnancy and also gives all of the various people that we would invite to be part of one or both of these committees the opportunity to just be on one of the other. And, I wouldn't want people to burn out or feel overburdened by serving on, a committee that might be getting more robust than what they signed up for. So I think these are different outcomes with different definitions and different time periods that we're looking at. And I think also having two separate committees gives the people that we want involved a little more flexibility.
And sorry, Dr. Bell, I see your hand, but I just want to jump in terms of the advice we've gotten from the law department and the way it's developed historically is that we needed to add, morbidity as a reportable condition, as you're all aware. So this sort of just is a little bit clunky in terms of the legal aspect of this as well. But I think, Sarah's point about how the committees will work together is what should be taken away. Dr. Bilal, go ahead.
I thought we had added morbidity as a reportable condition in 2023. This just adds the review committee, right? That's the big change here, as I'm understanding it.
Yes, going back to the mortality review and why those were so spread out. As I guess my point. Sorry.
Got it. So my point I wanted to make is that I do think that surveillance is still important here, even if it's not directly linked to recommendations in the regulation itself. Mostly because I think one of the things that happens is that luckily the numbers of mortality are small, are too high, but they are still small in terms of numbers. So it ends up being a condition that has high morbidity but relatively low mortality, probably because of the age of the population itself, as compared to other things. So it ends up being not a public health priority per se. It is for the health department, but I think it should be even higher, especially compared how bad the US is doing with respect to others. So I do think that that's important. I do agree that active surveillance takes a lot of effort, and that's why I think that using this in a feedback loop to improve the passive side of things can be really helpful. But that can only happen if there is a review committee to begin with doing the active surveillance.
Dr. Gold?
I want to say again that totally understand the reason, just following up on what Osama just said, we'll vote for it. Don't want to get in the way of the health department determining the need for more data. I do want to go on record as saying that it's my wish and desire that the crisis, particularly for Black maternal morbidity and mortality, crisis is what it is, and that it really requires some additional innovation that we just haven't hit. And no city seems to have hit it. So while it's great to hear about Maryland and case definitions and all of this, with all due respect, I have it in spades. I feel like we're using old tools from public health systems to get our arms around an issue that's been going on and widening now for decades. And it just would be a wonderful thing to put everybody in a room who needs to be in that room and say, this is unacceptable, and what are other ways that we can do it? It doesn't preclude the vote, and so let's move along. But it feels like very old tools in terms of data to get at an issue that's just been here and growing for quite some time.
I couldn't agree with you more. You know, you said it right. And I could go on for a whole host of reasons why the issue is what it is. We could go into a whole diatribe of patriarchy and public health, but I will not. I will pause there, and I will ask, I don't know that we have any members of the public on.
That's correct. There's no members of the public.
Can I ask just one thing, which I think is important, is that actually the Maryland regulation, remember I was there when in Baltimore when that passed, one of the things it had is money attached to it, to attach to solutions.
Yeah.
And I think that's very, very important. That isn't happening here because, I mean, it obviously takes a longer conversation. I'm hopeful that these numbers actually will help bring that money, I don't know, from the state or from the city.
I agree with you. I agree with you completely. And we are going into budget season. Dr. Gold probably remembers her days at the health department. It's always budget season, but we are, and we will, this is a priority for the health department. So we are going to do our best with the data and do more and be more innovative. And I can honestly say that our leadership, Dr. Mehta, who was not able to attend today, who's the division director, who thinks very much about being proactive and kind of leading in a way that I highly respect. I think we're going to make some significant headway on this issue. So we don't have any members of the public for public comment. So with that, I'd like to ask if the board has, if anyone has a motion or would like to make a motion about this regulation.
So moved.
Second.
I'll second.
Okay. All in favor?
Aye.
Aye. Ayes have it. Thank you very much. Sarah, thank you very much. You know, I think when I say to our overall staff meetings, when I talk about the Board of Health and I talk about the level of wisdom and intelligence and the questions that come up, one of the reasons why I love all of the staff being able to, you know, the division directors and the folks presenting, is that it really gives you an academic experience as well as an experience of how to do public health and be a public health practitioner, you know, in a setting where you're getting asked some challenging questions. So Sarah, thank you very much. Thank you, board. Can we queue up the next folks, Ellen and folks, to do the next regulation, which is about Philly's Families Can, a centralized intake data system.
Yes, let me pull up my slides.
Thank you. Thank you, Sarah. Great job. I'll be reporting out to Dr. Mehta.
Thank you all so much for your time and your questions.
Thank you for your patience with all our questions too.
Can everyone see my slides all right? Oh, what just happened?
Yep.
All right.
I
So
need to go to, sorry, slideshow mode.
oh, okay, I'm sorry. There, can everyone see this all right?
Yep.
Great. So I'll be presenting on Philly Families Can and a proposed regulation change. So Philly Families Can is a centralized intake and referral line for family support programming in Philadelphia. We primarily refer families to home visiting services, case management programming, and community resources. We serve families with children ages 0 to 17 in Philadelphia County. And we do this by a team of intake coordinators that talk to families over the phone. We do a short intake with them, figure out what services they are looking for, what their needs are. And then we walk through the programs that they're eligible for, and families choose which programs they would like to be referred to. We then send electronic referrals over to our network partners that provide the direct service, home visiting, and case management programs to families. All the services that Philly Families Can refers to are free and voluntary. And I apologize for all the small letters on the slide, but it's mostly to show you our workflow and the growth of Philly Families Can over time. So the boxes in blue are the original Philly Families Can structure. So that is a referral comes to Philly Families Can either from a family themselves or from a referring provider. It's then assigned to one of our intake coordinators who talks to the families, does that intake assessment. And then upon family choice, we send that electronic referral over to what was originally only a home visiting centralized intake. You can see through all the other colored boxes, we've really expanded since Philly Families Can originally started. So now we refer to family empowerment centers, which are DHS-funded community-based case management programs for families with children ages 0 to 17. That's the boxes in orange. We've also expanded our community resource connection, our warm handoffs, and connection to Benephilly, which does benefits access for folks. And then the boxes at the bottom in green represent our concrete goods fund, where with referrals from referring providers with funding, we are able to support families with direct concrete needs, such as helping assist with rental arrears and utility arrears and down payments to help families stay secure, stable, and in their home and healthy. So this is just to say that Philly Families Can has really grown exponentially since we originally started as a home visiting centralized intake. And you can see that over time, we've really grown in the number of families that we serve in a year. So in 2024, we received over 2,000 referrals to our intake line. And in 2025, we're on track to reach around 3,000 referrals. This is some 2024 data on where our referrals are coming to Philly Families Can from. So you can see a little under 15% of our referrals to Philly Families Can came from families themselves. And the majority of referrals to Philly Families Can come from referring providers. And the majority of those come from health providers and health clinics, followed by folks who find out about us through our website, and also health insurance providers are like Health Partners Plans are a big referring partner to Philly Families Can. And this is a list of all of our current network partners. I'd like to highlight Congresso and Gemma Services are the two programs that support our family empowerment centers, the DHS-funded community case management programming. And you can see we have some program partners that we refer to multiple programs within that one organization, such as Maternity Care Coalition, where we refer to 4 of their programs. National Nurse-Led Care Consortium, we refer to 3 of their programs, along with the division of REACH. And so Philly Families Can is currently a business associate of the HIPAA-covered entities in the Philly Families Can provider network. So the majority of the organizations listed in the previous slide, we currently have BAA signed with. So for our current network partners, we currently sign an MOU, an end user confidentiality agreement, and then a business associate with those who are HIPAA-covered entities. I can't speak greatly to the origin of Philly Families Can becoming a business associate, but as Philly Families Can has grown, it's become evident that our business associate status creates barriers for further expansion of Philly Families Can and what Philly Families Can is now grown to be. And so to formalize the current structure of Philly Families Can and to reduce barriers for further expansion, upon advisement from our law department, we're seeking to change our legal status to public health authority. And so one of our main examples for the barriers is that currently, in order to refer to the family empowerment centers, we must require written consent for families who want to be referred to those family empowerment centers. Which creates a barrier for those that we're talking to over the phone. That's really primarily how we do that. So there can be barriers to getting that written consent. And so changing to a public health authority would allow us to accept verbal consent from clients and would reduce barriers for families accessing support programming. The implications of this public health authority, the impact to Philly Families Can expansion on our service delivery, we would reduce barriers for adding additional network partners. We would then take away that additional BAA that all of our network partners need to sign, and it would reduce barriers such as that written consent that we're required to have folks sign at this point. Our impact to referring providers and families, there should be no impact to our referring providers, and only reduce barriers for families seeking to enroll in services. And would hopefully lead to us growing our network more easily, meaning that there being more network partners for families to choose from. And the impact on the PFCAN referral network partners, our operations and data protections would remain unchanged. Our data management and referral processes would also be unchanged. And our network partners would be required to sign revised MOUs. This change has been discussed with all of our provider network in 2024. Our provider network meets as a steering committee monthly with at least one representative from each of the organizations in our network at those steering committee meetings. And all of the HIPAA-covered entities within the PFCAN, the Philly Families Can provider network, are aware of the impacts of this change and have provided written approval of this change. Thank you, and that concludes my slides.
Do we have a question? Dr. Gold.
There it is. Sorry. Was this, just out of curiosity, was this outside the health department at some point? Like handled by a PHMC or something like that? Or just, it's so curious to me.
That's my understanding. It's the history is Elise Brule thinks it was the Health Federation, but we haven't found the original documentation yet.
It was somewhere else, and then it's pulled into the authority. And now, if you put the authority moniker on it per se, you get the functions of a health department in terms of HIPAA, all the things that we need to do, et cetera, et cetera.
Yeah, and the friction with the law departments with all the partners is so much lower. It's really, yeah.
Dr. Brian Stevens?
Yeah, so thanks for this, and I'm really applaud you for the work that you've done. I had a couple of just capacity questions. Does this regulation remove barriers such that your capacities increase, number one? And number two, do you have any thoughts about how this barrier has that been, do you have any data on how many families have not been able to get certain services because they couldn't provide their written consent?
That's a great question. I don't have the data with me, but I do have like at least anecdotal evidence from our intake coordinators who work with families that there have been points in time where they were unable to get that written signature and therefore were unable to send them to the family empowerment centers. I am really hopeful that with this regulation, it really puts us in a position where we can expand further and really increase our capacity to support folks.
And you mentioned insurance companies, some of them were partners. Are they reimbursing you for any of these services, or is this done without reimbursement? Just think about your capacity and your ability to.
Yeah, that's a great question. The majority of our health insurance provider referrals do not come with reimbursement, although we have had one contract with Health Partners Plans, and you can see that was where a big chunk of referrals came from in 2024, that we've had one contract with Health Partner Plans.
Okay, thank you.
Ben, do you want to share the regulation? And then,
Yes.
thank you. And then while you're sharing the regulation, I'm just checking at participants. Okay, we still don't have any members of the public, so we'll look at the regulation and then see if there are any more.
Dr. Ravel Nelson, before Ben gets started too, just to let the board know, we've received no email comments either.
Thank you.
Thanks, Jim.
Thank you, Jim.
Can everybody see my screen? Okay, great. So this is the regulation relating to the Philly Families Can centralized intake data system. The whereas clauses sort of lay out the functions and purpose of Philly Families Can and describe the centralized intake system and how it takes referrals from both individuals and partners. There's a definition section that sort of lays out all the individuals and partners in the department who are the players in this system. And really the operative part of the regulation is, as we've been discussing, formalizing the public health authority of Philly Families Can to cut down barriers on enrollment and expansion with enrollment of participants and expansion to participating provider partners. And then Section 3 sort of lays out the data flow that happens. So participants and providers can enter their information into the system, and excuse me, I should start with the PFCAN team can use the system to look at the agencies that have referred clients and review notes about the services that they've been provided to help with the centralized review and coordination of services. And then participating agencies are the ones entering their client information and able to enter the notes about their services that are then reviewed by the PFCAN team, as I just discussed above. And finally, there's the confidentiality provisions that state that this data is being held pursuant to state law, and that the data is inside the department is being only reviewed by staff who are authorized as part of the PFCAN team.
Thank you. Do we have any additional other questions from the board? If not, do we have a motion?
Move to approve as is.
I'll second.
Okay. All in favor?
Aye.
Aye.
I
Okay, the ayes have it. So thank you very much. Ellen and Jessica, great job. Again, Dr. Mehta, we'll talk with her in the morning. So board, we're about 7 minutes over, but I just wanted to give a brief update about what we're doing in terms of the SNAP support. And just, share with you, just say thank you for all the help that you've given throughout this year, for me in this role, and helping to build trust within where we need to be. So when everything happened and the city needed to move quickly to get food to hungry Philadelphians, the mayor was very adamant, and the health department was the department that was tapped on to help with getting funding out the door. Our division director for chronic disease and injury prevention, Dr. Chandriani, is on this meeting, and then Dawn Kieswetter, our EHS director, really partnered up because EHS focuses on outdoor feeding and making sure things are safe and healthy, and our chronic disease folks really work on getting funding out the door to organizations that do feeding and do it well. And we teamed up and worked tirelessly, got volunteers and worked tirelessly to we received about 2,300 applications, and Dawn and Kinnery, please stop me if I'm incorrect, received over 23 applications, and the team has been working around the clock. We had over 65 people from the health department and other departments throughout the city, mayor's office, DHS, all hands on deck. We created a way to created an application that was a 1.5 pages long for grant funding, and a robust review process. And, we've started emailing folks out of those 2,200 applications. We are funding over 130, and the grant funding is anywhere from 5,000 to 50,000 to help with groceries, prepared meals, and everything else. So this is just an example that I want to share with the board of good public health work, minding the public health safety, making sure that, and it was this board that insisted in 2012 that when we are feeding hungry people, that it be done in a dignified manner. Just because you can't afford food doesn't mean you're not entitled to safe and healthy food in a dignified manner. And that model was carried throughout the process. So after I don't even remember has it been a week, it's been nonstop. But the mayor's office and everybody, full support. So this is the work that the team at the health department, but more so under the mayor's vision, and the city's been doing. Philabundance and Share each received $1 million off the bat. I think it was Monday, the 3rd, that we had the meeting with the group there was a convening of over 200 participants, and Philabundance and Share. And then the remaining 2 million went to the health department to divvy out grant applications. And so those funds are going to be going out, and even with the SNAP benefits opening up, people will actually have food to feed their families. So
Great.
this is
Awesome. Yeah.
And I believe-
Congratulations. It's fun.
Thank you. And Ben, you will continue to get messages from Ben, like emails, just to give you updates. We'll give you an update on the Northeast Collaborative and everything, just so that you have the information. He will also continue to send information about upcoming council hearings and everything. So if you want to be a part of the public process of council, if you want students to attend, you'll be able to share that information. Dr. Ibrahim and I were on a panel last night, so the next time the tree canopy people are on, we can send students that way to get them to take part in those processes. Because I think right now, in this time and frame, we've been going around telling people when they say, well, what should I do? We've been saying vote. Now is the time to encourage people to get active and be active at all levels of government. So I just wanted to share that and thank the board.
That's great stuff. There's so many, because of all the crises, though, there are all these opportunities for quick hot washes. to take a look at, what took place, and for better or worse, you're going to have a blueprint for that situation. I have a close family member who gets SNAP, and today, just about an hour before our meeting, the card suddenly loaded automatically, and I was like, there it is, coming in. So that's great, but I would hope that under this mayor and through this great work, that some kind of op manual from the experience of this and how people fanned out, and whether or not that system that you use can be used for other similar crises. Because we'd all love to say there will be no more, but there's every indication that these waves are going to keep coming at us for a while. Great stuff.
No, absolutely. And that's one of the things that we forged a team that very quickly was like, okay, one person is just going to take notes and write the policies. And
Okay.
so, and I'm a big proponent, have been in government too long, not to have everything written down and to share it up so that folks are on the same page with us when these decisions are made. And we want people to be able to replicate, not just keep it within the health department, but other city departments, and be able to share. So it'll soon be, dare I say, a year that I've been doing this, and I just humbly thank you all very much for being such active participants. With that, do we have a motion to adjourn?
So moved.
Second.
All right, everybody take care. If we don't talk before Thanksgiving, have a great one, and we'll try to tee up a quick exec meeting in December.
Great. Thank you.
Take
Thank
care,
you.
everybody.
Much.
For everybody. Great job, team.